Welcome, and thank you for joining us in the session, Who Gets the Vaccine and How? Is there enough infrastructure and system readiness for access? Moderated by Dr. Amitav Banerjee, Professor and Head, Community Medicine at Dr. D.Y. Patil Medical College, Hospital and Research Centre.
Good morning, everyone. Am I audible? It's my pleasure and privilege to moderate this panel with very eminent and erudite speakers, very experienced speakers. We have got Professor Sanjeev Kumar, who has got 43 years of experience in public health, and he has been in the armed forces. He has been to the deserts of Rajasthan. He has worked in the deserts of Kenya also. He has worked in 29 countries in public health. In fact, I wouldn't waste time in that because anybody can do the Google search and just Googled and he has got. Similarly, Professor Raj Shankar Ghosh, he's also worked from the grassroots up. He has worked from the primary health center. He has worked as a strategic planner. Presently, he is advisor to the Bill and Melinda Gates Foundation and on vaccine delivery, which is very important. Here, the first challenge perhaps may be over. The vaccine has been produced and the first country to license it has been the UK yesterday, and again a mad scramble for who licenses it. So delivery is going to be the next challenge. So we have got Dr. Ghosh and Dr. Sanjay Kumar with a vast field experience in many countries. And of course, we have got from the major part will be played by hospitals. So we have got the president of the Asia Pacific Hospitals, that is Dr. Satoru Komatsumoto, who is speaking on what are the role of the hospitals and the priority groups, and particularly Japan, which is doing very well as far as COVID is concerned, probably because of in spite of a very aged population, they are the healthiest in the world, and they are having the least mortality from COVID. 1/10 of the global average and 40 to 50 times less than the Western countries. That itself something which is really fascinating. And so I would request Dr. Sanjeev Kumar to give the presentation. Each speaker will be speaking for 10 minutes. After that, we'll have a quick question and answer session for 10 minutes. So we will request the speaker to adhere to the time so that we can have exchange. So Professor Sanjeev Kumar, sir, please start.
Thank you, Dr. Amitav, and it's a pleasure and honor for me to be part of this August panel. Vaccine and COVID has been making headlines in the media and is on the top of our mind, both community as well as experts. So in my next 10 minutes of talk, I will highlight what we know about immunization programs in general and what we will be building on that. Then come to the 4 challenges we are going to face when we roll out COVID-19 vaccine. And I started my career as immunization officer in 1988 in UNICEF. So we are building on long legacy of immunization program. So first, let me talk about when you produce vaccine, what happens? You have a new organism which hits the humanity, and then you identify what is the structure of that. Within that structure, what are the parts of the organism against which you can produce vaccine? We call these parts as antigens. Then you have antibodies created in the body and destroy that organism. Then you do preclinical research on animals to make sure that it is safe, it doesn't do harm. Then you have clinical research on humans, and then you have 3 phases of research. And as Dr. Amitav said, many of these vaccines are on the either completed phase 3 or on the verge of phase 3, have met the criteria of safety and efficacy. Then it goes to manufacturers who produce the vaccine in sufficient amount. From the manufacturer till the beneficiary, it has to go in a cold chain. Pfizer vaccine, for example, is to be kept at -70 degrees Celsius, which will be difficult for countries like India and other to maintain that. Then you have vaccines which have come up minus 20 degrees Celsius, like Moderna vaccine. Then you have other vaccines like AstraZeneca and others, which India is looking at, which can be kept at 2 to 8 degrees Celsius. So transportation comes, then it reaches the distribution point, or we can call it vaccine storage point, where it is finally administered. Then the health workers pick up this vaccine carrying called vaccine carriers, and then administer it to the people. And the test of the vaccine is when it is delivered to people. Do I have faith? Government is saying take the vaccine. Do I go there? Even immunization programs which have been in place for 40 years have not reached 100% immunization coverage, both in developed and developing countries. So that public trust and willingness of people. So this is the flow. We have at international level some new development, Gavi, Global Alliance for Vaccine Initiative, that came into being. Somehow most of these things happen in January. So it came into existence in January 2000. And then you have January 2017, a path-breaking work on Coalition for Epidemic Preparedness and Innovation. January 27, it was conceived at Davos, World Economic Forum. The economy is concerned about how we develop vaccine against new diseases. It is the largest vaccine development initiative in the world, and it has done its job well. Encourage scientists, funded the research project, funded the production of vaccine, and cut down the time. Normally, it used to take about 10 years from starting research till getting vaccine. If at all you produced a vaccine, there are many diseases we are struggling with. We haven't got vaccine even after decades of work on that. Second point I want to highlight is we are building on a program called Expanded Program on Immunization, which was started in 1978 by World Health Organization and UNICEF. They realized that program is not reaching out to those who needed it the most. So in 1985, they gave new push and called this as Universal Immunization Program. And I joined UNICEF to supervise this program. Till 1990, we had received 80% coverage, and many of the districts I was part of, many of the states had only 15 to 20% coverage in 1988. Within 2 years, we reached 80% coverage, more than 80% coverage across the world, including developing countries, including the most backward states in a country like India. Third thing which has happened is the academia, the industry, and the funders have come together with initiatives like CAPI, and they are the ones who are, and then they identify which steps can be done parallel. You were going from one step to the other, to the next, and to the next. And what they have done is which steps could go parallel. For example, phase 2 and phase 3 clinical trial have been clubbed for many vaccines together. In-country initiative, and we are, I think, in the right direction. The health system has to deliver the vaccine, be it hospital, be it healthcare center. We have to keep in mind the routine immunization program. For example, in India, you have 27,000 vaccine storage points across the country, right up to peripheral level. A group of villages will have a primary health center, which will have vaccine storage point. It has two freezers. One keeps the vaccine as 2 to 8 degrees Celsius, other keeps the vaccine at minus 20 degrees Celsius. That obesity, epidemic of non-communicable diseases going on. And if you have non-communicable diseases, it's more likely to have a fatal outcome and more complication. So then the next point is you have to build on the existing program, existing healthcare care providers, maybe mobilize additional healthcare providers. For oral polio vaccine, we could mobilize semi-skilled workers, but this is an injection. You have to have more trained people. Then you could have coverage using oral polio vaccine, for example. So we need to have people who know how to inject the vaccine, how to take care of it. And then the last point is adverse events. If you have an adverse event, the system needs to be prepared, the media needs to be briefed, community level organization need to be briefed. Here, this is the vaccine, these are the common side effects. And there are unrelated side events which can happen. If a child or an adult can die after getting a vaccine, but not related to the vaccine. So there are other diseases which are killing children today, killing people today, which can kill them. So correlating unnecessarily to an event which has absolutely no contribution, that is important. Coming to the four challenges I have, there are country interests which are diverting supplies. For example, Canada has already paid the money for vaccinating the whole population with 9 doses. You don't need it. You need only 2 doses. Second example, UK. They have procured enough vaccine, paid for it, to give 5 doses to every person in UK. US, close to 5 doses, 4.8. EU, more than 3 doses to every citizen in EU. This money has been paid. What will happen? This will divert supplies. So there is an effort required at international level to negotiate with them. You keep the vaccine unit, give us the rest of the vaccine, which can go free. You have paid for it, which can go free to the countries or to the community groups which cannot afford to buy the vaccine. India, for example, has already placed order for 1.6 billion doses, more than 1 dose per citizen. So all of us are competing with each other to place orders, and that may affect equity and availability. There are politicians who are trying to show, like China, Russia, they have local produced vaccine which they have already approved. UK has approved a vaccine using international benchmark, but these two countries approved vaccine. So they are competing with each other at time, not looking at scientifically valid time where they can say, no, we are ready. Everything has been checked. International experts have looked at the data, and we can now go vaccinating large number of public trust. I mentioned very important to keep them informed. These are the side effects which will happen, and if there is any unrelated, we need to look at the media. We have no experience in adult immunization in most of the countries. We need to keep that in mind. And it is an unprecedented scale of vaccination. We need to address that. So these are the 4 challenges we will face when we roll out immunization of the population for COVID-19. But good news, we are almost there. Vaccine is coming, and we will get the vaccine. Another tool, not the only tool. It is another tool to prevent disease. People feel, no, we will stop wearing mask and we will stop other. No, you have to continue doing that. So with that, you will have another tool to prevent the infection. Thank you so much. Back to you, Dr. Amit.
Mute myself. Professor Sanjeev Kumar, thank you so much for that quick and overview. Now, another problem which has already occurred, and setback which has occurred, and which one can have concern that with the diversion in COVID vaccination, there may be neglect of the routine immunization of children, and particularly for a country like India, where the daily 2,000 children die every day due to preventable diseases. 2,000 children die, and much of the vaccination, the routine vaccination, had been interrupted due to lockdowns. And what we fear is, because of all the resources we are going to piggyback on the existing vaccination cold chain resources, what is the impact of the collateral neglect of vaccination, particularly child? For that, Professor, I would request Dr. Ghosh to give his presentation on the effect on the other vaccination.
Thank you, Professor Banerjee. First of all, let me thank the organizers of the Asia Pacific Patients Congress for inviting me to this talk. And let me say what a privilege it was to hear Dr. Professor Sanjeev Kumar speak so eloquently on the challenges and what we need to take care of for COVID vaccine. As Professor Banerjee said, I'm going to focus on the routine immunization activities in India, the disruptions that we have seen, and what guards we need to take about ensuring that the coverage and equity of routine immunization continues. So my topic is immunization, keeping people at the front. One thing that we must remember about vaccines is that vaccines per se do not save lives. It is vaccination, the program, that ultimately ends up saving lives. We can have hundreds of vaccines, and if those vaccines don't reach the people, if we don't have high coverage, if we don't have equity, the number of vaccines that we have does not make any sense. The construct of the presentation that I am having today is first I will lay down a few principles of immunization so that we are all on the same page. The second is I will speak a little bit about the disruptions that we have seen in the routine immunization program with COVID-19 pandemic and the lockdown. The third, I will speak a little bit about the resumption of the RI services, routine immunization services, the innovation, the grit, and the resilience that Indian frontline workers and program managers have shown. And there is one slide that I'll talk about marching forward. So first of all, we need to remember that what is an effective immunization program? An effective immunization program has a 3P construct: a product, which is the vaccine, place where the vaccine is given, and people who will receive the vaccine and who will give the vaccine. So what is an effective vaccine delivery? Effective vaccine delivery is the availability of a safe, efficacious, and affordable vaccine at a place that is accessible and acceptable to the community, where trained health workers deliver the vaccine to people who are well informed about the vaccine which they or their dependents receive. All the words, the safe, the efficacious, the affordability of a vaccine is important. It is important that the people who receive the vaccine are aware of what they are receiving. We need to really work on our information, education, communication, social mobilization tools that will reach the population to educate them. And finally, the people who are giving the vaccine need to be trained about giving the vaccine, and also the place where the vaccine is given needs to be accessible to the population. We should do it at a place where people can reach, and also it needs to be acceptable to the community. All of these, Dr. Sanjeev Kumar had already highlighted about how we need to think about trained people. He was citing example of polio vaccination, and now the COVID vaccination is an injectable vaccine. So we will have to think of training the entire lot of vaccinators who will give the vaccine. We'll come to that later. The second point that I want to speak about is that immunization for long had been a very vertical program, which completely came as one program that disrupted systems, reached to the population, and gave the vaccine that it was due. Now, as Professor Kumar was speaking, we have reached 80% and above. India is now targeting 90%. Our Honorable Prime Minister has said that the goal is that not a single child should be left out. We have to think differently. The immunization program now needs to become a part of the universal healthcare and the primary healthcare system. So what is a robust immunization system that we need to talk about? It is on 4 pillars that it will rest. One is integration in the universal healthcare. Second is it needs to be fueled by innovations that are generated by necessity, which are affordable by the countries and the community, easy to adapt and adopt to the existing system, and those that can be scaled up rapidly. A good example of an innovation in vaccines is the vaccine vial monitor, which helps us to understand the stability of the vaccine in the temperature in which the vaccine is kept. The UniJet has been an innovation that UNICEF led from forward in order to ensure that there is a safe vaccination following the AIDS epidemics and all of that. The third is talking about the impact. We need to measure and evaluate our programs to make course corrections We need to have strong disease surveillance systems to identify pockets where we have missed immunization, where immunization did not reach the vulnerable population. And finally, the program needs to be well resourced. The investment needs to be high in the program. And when we talk about investment, there are three kinds of investment. One, the funding for the program needs to be appropriate. The second is the investment must be made in the frontline workers who are going to give the vaccination. And we must invest in our domestic institutions like the National Institute of Health and Family Welfare, the other institutions that are there, the Indian Council of Medical Research, the Department of Biotechnology, in order to take the immunization agenda forward. So now we will come to what happened during COVID-19. All of us are aware of the scenario. The first case was reported on January 30 in India. The first death happened on March 12. The closure of all services, particularly the outreach services, happened on 25th of March. For 21 days, there was a lockdown of the outreach services from March 25th to April 14th. On April 15th, the second lockdown was announced, but the resumption of the RI services was begun. Then there was a third lockdown, which was from May 4th to May 17th, but the RI and other essential services continued. There was a fourth lockdown from May 18th to May 31st. However, all essential services at outreach centers were being provided. But after the May 31st, when the last countrywide lockdown was there, immediately after that, the Japanese encephalitis vaccine campaigns were started in Bihar because the season was approaching for Japanese encephalitis to happen, and we needed to protect the population. So the state launched the Japanese encephalitis vaccine campaigns. And finally, with the unlocking, which was initiated on 8th June, all the states then came together to find a way to resume the routine immunization services in their countries, in their states. How they did it, we'll come to it later on. So what was the impact? We will look at three different vaccines. The first is the BCG vaccine, which is given at birth. What did we see? What we had targeted, that there would be 17.6 million children who would be vaccinated by August with BCG vaccine. Last year, by this time, 15.4 million children were vaccinated. However, the impact was such that 12.6 million children were only vaccinated, and we missed out about 5 million children who did not receive their BCG doses. And where is this data from? This is from the Health Management Information System, HMIST. What happened to the pentavalent third dose from January to August? We had targeted that, sorry. Yeah, sorry. So again, we had targeted around the 18 million children. We only were able to cover 13 million children. We last year had covered 16 million children, but this data is still August. A huge improvement has happened after that, given the passion and the energy with which and the innovations with which the frontline workers have moved on. We have been able to make up in the country the kind of loss that we had in terms of the reduced number of coverage. So this data, please take up to August. Till October, we have much better data. I have not shown that data because the HMIS data is being verified. Once that data is available, it will be uploaded on the ministry site. Please visit the Ministry of Health and Family Welfare site, and you will get all the data that you have. Similarly, in case of the fully immunized children, it was targeted that 16.2 million children would be vaccinated. 18 million children would be vaccinated. We last year vaccinated till August 16.2 million children, but we could only reach 13.5 million children till August. Again, I would like to repeat that by October, we have been able to make up a lot because of the additional sessions that have been planned. And I will come to you about what are the other plans that the government of India has with its partners in order to address this issue. So what were some of the innovations that happened in the field in order to mitigate the loss that we have had in the program? The first was the session organization, where rapid data analysis, identification of alternate sites, the mothers were given token numbers, mobile sessions were created, and logistic management was a very important component. In terms of the use of the information, education, communication materials, the IC materials were displayed on the buses, the dumpers, on the mobiles, the message was sent. SMS was created. SMS means social distancing, mask and sanitization. The message was given very loud and clear to the community. Television, radio, all forms of messages were used. In terms of technology, virtual platforms were created to review the progress at the highest level of the principal secretary, who really communicated frequently with the district magistrates. Capacity building of the health workers was done, and the daily reporting in states like Bihar and in Chhattisgarh were done. Mobilization, UNICEF partnered with the government of India to do this. The mobilization of beneficiaries by ASHA telephonically, awareness on immunization by house-to-house visits. ASHAs really led from the front in terms of the mobilization activity. In terms of the stigma address, which became an important issue, our Honorable Prime Minister stepped in with a very strong message. The sensitization workshops were conducted by the districts, the district magistrates, and even legal actions were taken in order to prevent any stigma that was in the public towards the health workers. Finally, adhering to safety guidelines, there were deep freezers and vaccine carriers which were used only for COVID-19 samples, segregated. The sanitization of all vaccine carriers and cold boxes were carried out. Safety precautions were taken absolutely during the sessions. And finally, demonstration of hand washing was shown. You had all seen the video that the DG of WHO had shown. And then at the district level, many district magistrates also showed the similar demonstrations to the community. Finally, marching forward, we must remember that the center of any vaccine policy and planning should be people. That is why I'm very happy to speak at this conference, where people are the center of the discussion. Our ANM, ASHA, Anganwadi Didis, they need to be trained in people-centric communication, which is around their awareness, around their apprehension, around their issue of access to the services. The key to high vaccination coverage and equity is a strong immunization system. Unless we improve our primary healthcare, universal healthcare immunization program won't be sustainable and won't be robust enough. Lastly, we need to remember that every life counts. Life which is next door, life which is at the last door, at the last mile. Only then will our immunization program become successful. Thank you very much for the opportunity to speak.
Thank you, Dr. Ghosh. We have the perspective of two eminent public health specialists. Now we'll have a perspective of an eminent clinician and hospital administrator. Dr. Sataru is an eminent neurologist and he is the president of Asia Pacific Asia Hospital Federation. I request Dr. Sataru to give his perspective.
Thank you for introducing me, Dr. Amitabh. Before I start my presentation, please give me 1 minute to congratulate you on this Congress. On the occasion, Second Asia Pacific Patient Congress, I would like to express my sincere congratulations as President of Asian Hospital Federation, as well as it is quite honorable for me to be given the opportunity I make speech in front of you. As you all know, it has been 1 year in which medical professionals required to take on big challenge in 2020. The pandemic coronavirus infection has had a great impact, not only on medical field, but also on various fields as politics, culture, and economy. Under such circumstances, amidst hardship caused by outbreak of COVID-19, Second Asian Pacific Patient Congress is convened virtually as a result of the effort of official and concerned people, International Alliance Patient Organization. It is truly remarkable, a good model for all health service providers in neighboring Asian countries. The wonderful lectures are very enthusiastic discussion are expected. First slide, please. My first slide, please. Please.
Yes, are we having problem with your slide? 1 second, let me just.
Okay.
Can you open from your end, please?
Our session's main title, Who Gets a Vaccine and How?
Yes. I think we'll have to ask is your assistant with you? Could you open from your computer, from your laptop to share with us, please?
I cannot share.
Okay.
So if it is the presentation that you had shared, then probably Dr. Banerjee or I can try to find out that presentation.
Please do that quickly, yes.
Okay, let us try to do that. Dr. Banerjee, are you doing it? You're on mute.
I have already sent my PowerPoint. Can you manage from the first slide?
Just give us 2 minutes. You can in between speak to the audience and we will try to find it.
Okay, anyway, I want to using slide 2. This subject is split into 2 separate but important subjects. I'd like to start with the first, which is who will be vaccinated during the initial period when vaccine supplies certainly be limited. Clearly, we will need to establish some kind of prioritization scheme. No doubt, nature of this scheme is different between. Yes, please. Okay, that's fine. That's good. I feel as long as system produce positive result. For your consideration today, I'd like to overview the framework of vaccine distribution for Japan. Japanese government is making its best effort to secure necessary vaccine supply. Of course, common sense tells us we cannot vaccinate all the target population at once, given the limit of supply inoculation system itself. So we need to set priorities for who to vaccinate first, and in what order. What's more, these priorities will need to be continuously reevaluated from the perspective of fairness, while also considering state of pandemic, supply of vaccine. Our goal to prevent spread of infection, to prevent serious infections. With that in mind, it seems that, at least initially, we should be giving priority to the elderly and those with existing health conditions, as well as to the medical professionals who are directly treating patients. At present, it is difficult to ensure that new coronavirus vaccine will have the same level efficacy and safety as other vaccines. With very track record to go on, data about vaccine safety and efficacy will also likely be limited. Next slide, please. Slide 3. Vaccination priority. Vaccination supplies will certainly be limited, especially initially. However, considering the purpose of vaccination, I expect most would agree inoculation priority should be given to medical staff who provide direct medical care to coronavirus patients as well as patients suspected of infection, and paramedic or others involved in transporting potentially infected patients. Next, elderly and those with underlying condition should be given high ranking and vaccinated. We should begin considering exact range, individual and condition that will cover as well. Priority for those individuals who work in facility, the house, the elderly, those underlying illness, handicapped, should be variated based on nature of vaccine and of their duties. Slide 4, please. Effort for commercialization of new corona vaccine. Government will accelerate entire process from basic research on the development new corona vaccine to regulatory approval and production. In Japan, Shionogi Daiichi Sankyo, KM Biologics, are developing vaccine at domestic manufacture. And Japan will also work to secure overseas vaccine, improve the inoculation system, put the vaccine into practical use as soon as possible. First important issue, speeding up research and development as well as pharmaceutical affairs examination. Next, production system will be improved in parallel with development and research to shorten period until start of supply. In addition, in order to secure vaccine from overseas, we will discuss with Pfizer, US, AstraZeneca, UK, about the domestic supply vaccine. Next, slide 5, please. Securing vaccine. In order to improve life and health of students, reduce the burden on medical system, and secure socio-economic stability, Japanese government aims to secure enough vaccine for entire population of the country by the end of the first half 2021. When securing vaccine from overseas, it will be necessary to make some decision to purchase, even though safety and effectiveness of product may not yet be clear. Of course, when securing vaccine, it is important to give some consideration to other countries so that Japan is not seen as monopolizing supply, and government plans will reflect that. Slide 6, please. At present, it is difficult to ensure new coronavirus vaccine will have the same level of efficacy and safety as other vaccines. Debate about whether to fast-track distribution of vaccine given the severe condition of the pandemic, or to focus on safety regardless of whether it means the disease continues to spread quickly, is likely to be polarized. At present, much is still unclear about efficacy and safety of vaccine being developed. As such, we must continue to gather as much information as we can. In particular, unique risk presented in this case. Many of new vaccines that are coming being developed with cutting-edge technology, such as viral vector, nucleic acid. It is possible these vaccines will carry potentially serious side effects, such as antibody-dependent enhancement, ADE. It will be necessary to strengthen our safety monitoring method prior to beginning to any broad inoculation program. Of course, since it's ultimately individual who makes the decision whether to be vaccinated or not, based on risk-benefit analysis. It is crucial that we can also provide information needed to make informed decisions. Generally speaking, there has been no particular example vaccine for respiratory virus was so effective as to completely prevent infection. Therefore, while we can hope vaccine will prevent serious illness, it will be necessary to evaluate its ability to block infection or development of symptoms at some future date. But for now, it is necessary to assume that reasonably effective vaccine will be developed and to prepare for its arrival. Slide 7, please. Inoculation system. During 2009 influenza pandemic in Japan, Japan gained experience with developing special legislation to deal with epidemic of this type. This scheme can be applied to COVID-19 countermeasures. For carrying out mass vaccinations, each of Japan's major administrative divisions, national government, regional government prefectures, community municipalities has their own role to play. National government need to take initiative in fight against the coronavirus. For actual inoculation system, it is crucial to develop something that is simple and effective to avoid confusion at the implementation level, while taking into consideration unique conditions in each region. It is important for regional government, medical institution, regional medical association to work all closely together and to avoid burdening local government. It is key for national government to smoothly implement financial measures needed to support them. In addition, developing a system to ensure quality distributed vaccine is also essential. With these measures in place, we can reduce number of deaths seriously ill patients from COVID-19 as much as possible and prevent further uncontrolled spread. Doesn't this answer the question, who gets vaccine and how? The result of this should be achievement of purpose of vaccination in the first place. Next, please. Slide 8, please. Who gets vaccine and how? Due to initially limited supply of vaccine, healthcare professionals who work directly with new coronavirus patients, emergency personnel involved in transporting infected patients, and public health care workers should be first. Then, elderly and those with underlying illness should be prioritized for vaccination. From here, scope of the vaccination can be gradually expanded to those employed at facility where high-risk people such as elderly live in groups and to pregnant women. Depending on situation, further expansion inoculation range should be considered based on latest domestic and foreign findings about the virus. For the actual implementation system, national government will take the lead and cooperate with local communities to establish efficient inoculation system. Since it is ultimately decision of individual whether or not to be vaccinated, it's crucial to provide information so that residents can make a comprehensive risk-benefit analysis. Last slide, please. Okay. With a measure in place, we can reduce number of deaths and seriously ill patients from COVID-19 as much as possible and prevent further uncontrolled spread. Doesn't this answer the question, who gets vaccine and how? The result of this should be achievement of the purpose of vaccination in the first place. Thank you for your attention.
Thank you, Dr. Sataru. That was a very wonderful summing up of the priorities. And before we just have a time for a couple of questions, I would just add one comment as far as Japan is concerned. Though, as I said, Japan had a very low mortality and morbidity. But I think the International Olympic Committee should bid for vaccine for Japan to break the transmission at Japan, so we can have the next Olympics as soon as possible. I think we can take that as a leverage that we can have a Olympics in Japan as soon as possible. And now we have got just time for a couple of questions which we have received from Dr. Kamal, who is a monitor of national polio surveillance. I think these questions are directed at Dr. Raj Ghosh. One question he has asked is how long we require to train all the human resource to deliver the vaccine for the whole country? How long will it take? You're mute, I think. You're mute.
Yes. Sorry. So first of all, thank you so much for asking this question. There are two things that I will say. One, it depends upon the scale of planning that is there. I just replied to Dr. Ratna Devi, I think, on the chat, that India has now developed a very robust plan which contains both the online and sort of physical training that is required from the national down to the district level. It will be launched as early as this week, and it will continue over the next a few weeks in order to complete it. In the planning, we do not see much challenge because there will be healthcare workers, there will be additional healthcare workers who will be identified from other sources than from the normal UIP program, those who are eligible for injection. But I can say tell you with confidence that the planning is such with the government of India, with the partners and with the states, that we do see that we will be able to complete the training in the stipulated. It will be a mix of online and physical.
And of course, the second question is whether we should know the immunology before giving the vaccination. I mean, that I didn't know what it means.
That is not something that we can at this point test before we give the vaccine, because the question rather is whether the COVID positive patients who have been in the past should receive the vaccine. There are various policies that are being determined on this by the Indian Council of Medical Research and NECVAC. What we know is that there is an immunity which is developed after the infection. The period of that immunity is not very long. So we need to understand whether we need a vaccination in order to boost that immunity, or we should prioritize the vaccine for the non-immunized population. So that is a question which is still pending.
Moderator Chair, could you, the time's now up. We need to start the next session. So could you wrap the session up quickly? Thank you.
Thank you, Kamaldeep. I'll just sum up in a couple of sentences. I thank all the panelists, and from what I could gather from the deliberation is that we have to go for the high risk group first, the health workers first. And I was just seeing that it is something we are going towards focused prevention. I mean, this term came up in the Barrington Declaration. So what I feel is whether willy-nilly both are going in the same direction. That the Barrington Declaration advocates, they say that whatever available, that social distancing and all for the high-risk group. And similarly, the vaccine, we have got a vaccine now, but we cannot roll it out to the whole population. So we give it to the focus. We are again going for focused prevention. And to roll it out for the whole population, may take 3-4 years. We cannot keep the whole institution closed, school closed, workforce closed. So ultimately, we are the vaccine advocates also are going to the focused prevention there by compulsion. And similarly, the Barrington Declaration. So I think there shouldn't be any antagonism between the two sides, which has this COVID has polarized the scientific discussion. It has they should come together and to find a common solution without any antagonism and polarization. I think with this message, I thank once again the organizers for giving me this opportunity and the panelists for covering up in such a short time a vast perspective, different perspectives, and thank you so much. Thank you.
Thank you.
Thank you, everybody. Thank you.
You.